Well, thank you all for coming to join us in this conversation about disrupting Alzheimer's and really thinking about where we are and right now, the state of the research, of public awareness. And thank you, Harry, for joining us today. One thing I thought about when I was invited to moderate this was we talk so much about in the medical conversation, so much of the language is about crisis, right? And crisis is a term we associate with something bad, but in medicine, it means a point in which we can tell if the fever is breaking or if it's going to get worse. Do you think right now, today, the state of the Alzheimer's research and discourse, are we at a crisis point?
Well, given what you've described, Vann, I think that we are indeed at a point where we might be seeing that break in the situation you're speaking to. You know, we've had many drugs fail, of course, in clinical trials, and a lot of attention gets paid to that, and rightly so. We have learned, though, from those failures as well, learned much. We've learned from research the association did more than a decade ago about the onset of the disease, the accumulation of the plaques in the brain as much as 20 years in advance of symptoms. We now have that technology for the tau, the plaques and tangles of Alzheimer's. Those are big advances. We've seen other huge advances recently in other ways altogether, in, for example, the management of hypertension through the SPRINT Mind study that now points to the potential for risk reduction in altogether different ways for the variety of dementias that evolve through MCI.
What to you is the most misunderstood thing today about Alzheimer's?
Well, certainly you're going to have scientists speak to you. I'm not a scientist. I'll defer to them to talk to the greater detail of the course of the disease. But certainly there are many things at a basic level we still don't understand that limits our ability to do the kind of drug targeting that would be otherwise much more advantageous. But you know, the association's worked hard with members of Congress, leaders in the Congress, for many years now to advance the research funding. I'm proud to say that we've advanced that now to $1.9 billion annually from what was only $400+ million annually, with another $425 million pending. Now, I will tell you too, though, that that's still not enough. If you look at the number of trials we have going on today in Alzheimer's compared to cancer, for example, we have comparatively few. Now, you can quickly say that cancer is more than 100 diseases, and that would be right. But we also know now from the research that Alzheimer's is heterogeneous and likely also mixed with other dementias. So we need to continue the research funding, but as a result of what has already occurred in that funding, I believe we are on what is ultimately a disruptive path in terms of the very nature of the purpose of the conversation today.
So we talked backstage about there being sort of a curve for understanding diseases, for understanding how to beat them, how to disrupt them. Where would you say Alzheimer's is on that curve compared to other diseases that are sort of in the top 10 of the biggest mortality burdens on Americans?
Well, I personally worked in cancer for many years. You know, it wasn't all that long ago that no one even spoke the word cancer. As late as the 1960s, it wasn't addressed in that way. Doctors didn't tell their patients when they made a diagnosis. 90% of them at one point in the 60s didn't tell their patient about the diagnosis. That's all changed. We now have, as a result of what is a conversation in the public about cancer, which is fundamental, I will tell you, I believe, that as a result of that conversation, we then saw the mobilization of the war on cancer. You can argue about the success, perhaps, but I will say this, about 2/3 of cancer patients survive today. Now, we don't yet have that in Alzheimer's. So if you follow that curve that you're talking about, you raise the discussion, and I believe the association, I can tell you, has worked hard on that to raise that discussion in the public. The public now has that attention to the disease. We have gotten Congress's attention to the disease. You raise the discussion, increase the funding, get smart people working on the disease, and one of the things that the new funding has done is attracted people from other disease categories, not just Alzheimer's. So that means altogether new thinking coming along with the great in-depth thinking that was already present in the space. So those things, I do believe, have us on the point on the curve that set us to be ready for what will be those advances we've now seen in cancer. Now you've got certainly people who you still have to fix in cancer.
Right.
And we've got a long way to go here, but I believe we're on that path.
Let's talk more about the public discourse, about what people think about, the layperson thinks about when they think about Alzheimer's. It seems that a lot of the barriers in the conversation have been related to the fact that it's a disease that's associated with age. And there are lots of sort of ageist strains to our conversations about health generally. Do you think that's a barrier, and what would you identify as the largest barriers to getting the public on a healthier path to discourse about Alzheimer's?
Well, it certainly has been a barrier over time, and I won't say that it's fully gone away because it still exists, there's no doubt, and we've made great advances in the discussion of the disease, raising the public's concern to what is something that's commensurate with the impact of the disease, but we still have stigma that causes the kinds of problems you're describing. Nonetheless, even given those factors, we've still got to advance on that stigma. But even given those factors, we know from the polling that we do that young people, millennials, are as concerned about Alzheimer's and dementia as about anything as it relates to their own retirement. So we've managed to advance the discussion into younger age groups because they have seen what's happening to their family members. My mom had the disease. My wife's mom had the disease. When you see it up close, you are affected in ways that make you want to change this, and that potential to mobilize communities across the country has been no small part, along with our direct connections in working closely with leading members of Congress to write the National Alzheimer's Project Act, the Alzheimer's Accountability Act. It's also been the mobilization of hundreds and hundreds of thousands of people across the country of all age groups who want to change this.
By the numbers, are we expecting that since people are living longer, since we are seeing the mortality burden of Alzheimer's and dementia rise, are we seeing more people, more young folks who are more experienced with understanding and who are touched personally?
Regrettably, we are. You heard some of the statistics at the outset. You know, we've got more than 5 million people who have the disease today, going up to as many as 14 million by mid-century, and 3 times as many caregivers with those numbers of people who have the disease. And tens of thousands of those caregivers are teenagers. Mm-hmm. We actually have many, many young people who are the primary caregiver for someone who has Alzheimer's. So regrettably, as those numbers increase, the numbers of young people who are affected not only indirectly, but very directly as caregivers themselves, those numbers are increasing too. So regrettably, more and more people are seeing the disease. You know, it's not normal aging, but age is the biggest risk factor.
Right.
So as the population ages, so will those numbers increase.
You mentioned caregivers. We are going to have a conversation about caregivers later today, but it seems when we compare the caregiving workforce to other healthcare industries and other workforces within healthcare, they don't seem to be as well understood how the dynamics work. Is that part of the conversation now, understanding caregivers and how that all works?
It certainly is. You know, there are multiple facets, of course, of the caregiving side of things. One of the benefits of the increased funding is to get more research done with caregivers and caregiving overall, and we're learning much more about that. We already know, though, a lot that if we could get it implemented, would make a huge difference in people's lives. So the association's working with public policy, of course, at the federal level. We've seen the HOPE Act converted into a billing code for Medicare so that we can get support for families. We're working on that at state public policy level. And we just issued a new set of care guidelines published in a special issue of the Gerontologist. And our aim is going to be to get those adopted at state level, in public policy and also then in private policy by working with health systems where we have not historically had the kind of implementation of that level of care that we need. So you're absolutely right. We've got work to do there.
You mentioned Medicare. We're talking about, usually when we discuss other healthcare issues, so much of the language, if you're talking about obesity, if you're talking about diabetes, the language is about externality, sort of the push for curing diseases is about, okay, it costs us X amount, and we can save on cost by moving towards disruption. How has that particular line of debate and dialogue about cost, about Medicare and Medicaid, about how those programs have ballooned and evolved over the last few decades, influenced your work and influenced what the public thinks about Alzheimer's?
A huge impact on all of those things. We've talked with the members of Congress for quite some time now, and I think successfully so, in getting them to recognize, first of all, the human impact of the disease. It's devastating, as so many of you here in this audience know from your own experiences. It's a devastating disease to the family members, the caregivers, as well as the individual who has it. But the cost, as you heard at the outset, $277 billion in hard costs, most of that Medicare, Medicaid. Medicaid is the only place you can get residential care if you've run out of other resources, and those costs then for Alzheimer's and other dementias are huge and growing rapidly. Medicare also bearing a huge burden. So those costs will go to $1.1 trillion, we estimate, by mid-century if we can't get this path changed. I believe we can, but that's what we're facing if for any reason we did not. So the Congress has recognized the impact of these costs and has acted then to make these investments in research, which again, I believe still need to continue to rise to get to where we need to be, but they do recognize this impact. One of the leading proponents of these increases has compared it to the defense budget, that those costs today are roughly half of today's defense budget, and if we rose to $1 trillion, that would be roughly double the current defense budget, to put it into context. So those burdens are huge and growing.
I want to, if we can have one person come with a question in the next couple seconds, but I'll ask you a closing question before we do. You know, I think a lot of the conversation, a lot of the sort of fancier and more sensational journalism is going to be about the search for a cure. We're looking at one thing that's going to be the silver bullet. But where are we in thinking about these other things along the continuum of care, detection, and understanding the earlier stages of the disease where we can actually improve outcomes?
Well, I think the Sprint Mind study I mentioned is probably the best answer to this in the near term. We now know, as a result of that study, that if you manage hypertension to 120 or below, that the risk of mild cognitive impairment is reduced by 1 out of 5 individuals. Now, the study was so effective that it would have been unethical to continue it to determine just how much of all dementia would ultimately be prevented. But we at the association have the advantage to have contact with the global experts on these topics. I'm again no scientist, but we know the best ones, and they believe that those numbers will largely hold. That in fact, now, as a result of that science, we can effectively prevent, risk reduce at least, huge parts of what are mild cognitive impairment and potentially then dementia as a result of interventions that just not very long ago weren't being thought of as the path to the kinds of answers you're asking about. So I believe, based upon the access to all of those scientists, it will be a combination of providing that kind of intervention for risk reduction, the kind of drug announcement we saw that you'll hear about no doubt later from scientists at our international meeting, which we held here in Chicago this year, about 6,000 nearly all of them researchers, convened, and that announcement said that there's a drug, again from ASI, that actually showed effective clearance of amyloid and a reduction, at least, in the decline in cognitive ability. So those are different pathways, but the combination of the multiple pathways should lead us to the potential to intervene, treat, and again, as you also said, provide better care on the path to those answers.
I think we'll have to save our question for the next session. I'll be back. So, well, thank you so much for joining us and for starting this conversation off in such an amazing way.
Thank you. I appreciate it. I believe we're on a positive path. We've got a lot to do, but we're on a positive path, I believe.
Well, thank you all.